Welcome everybody to tonight's webinar. We are joined by Dr. Gurdev Parmar and Dr. Sarah Souls to discuss hyperthermia in oncology. For those of you who don't know, Dr. Gurdev Parmar, he is currently one of the ONC-ANP board members. He is also a FABNO. I believe he was our first Canadian FABNO in the first batch of Canadian FABNOs, if I'm not mistaken. And
2007.
does that sound correct?
Yeah.
Yep. He's been involved in lots of different associations as well as on a kind of state or a provincial level, I should say, not a state level. And he is also currently the president of the International Clinical Hypothermia Society. So that kind of adds some extra street cred to his knowledge on the topic we're talking about today. Many of you probably don't know our co-presenter, Dr. Sarah Souls, and we're very excited to introduce her to you all. She is currently kind of a little bit more than halfway through her first year of a 2-year naturopathic oncology residency program with Dr. Parmar. She graduated from CCNM, and she, as a student member, was very involved in the ONC-ANP, helping out with the No database project, and which she continues to do, and we're so excited to have her present. I wanted to highlight that she is our first resident to do a webinar, so we're very excited about that. And without further ado, I will pass the floor over to the two of them.
Thanks, Corey.
Thank you, Corey.
Okay, well, welcome everybody. I am thankful that people have decided to join us tonight. Sarah and I are going to be talking about hyperthermia in oncology, and this is more of an update. There have been previous lectures at ONC-ANP conferences and others where I have presented on hyperthermia in oncology, but this one is an update, some of the things that have happened over the past year or two that we think are very interesting in the research of hyperthermia, particularly the type that we use. And also, this lecture is going to be an opportunity to introduce our audience to all the various NDs and clinics across Canada that are now offering hyperthermia. And I'm very happy to present all these other clinics that are offering it. So for those of you who are interested but don't have the facilities to offer the treatment, I'm hoping that at the end of this webinar you'll know where to send your patients if you're interested in them receiving this treatment. Sarah, anything that you would add to that?
No, I think we're good to go.
All right, next slide. Okay, so as a way of a brief outline, we're going to just touch on some of the basics of hyperthermia and why it's used in oncology, a little bit about the history or the tale of hyperthermia's introduction here in Canada, and now, as I just mentioned, which facilities are offering the treatment across Canada now. And then Sarah's going to take the floor. I'm the old guy in between the two of us, so I'm well prepared to do the historical stuff and more of a how did we get here. And then Sarah, you know, she's an excellent resident, and she's going to be an amazing naturopathic oncologist, and so she's going to take us into the next, the last piece of the webinar, which is actually the probably the longest part, which is some of the research updates and things that we're keeping our eyes on. So as a way of a disclosure, I own Integrated Health Clinic. We offer hyperthermia treatments. And I also have ownership interest in a company called Tenuvita, and we distribute hyperthermia equipment across the world, including here in North America, Canada and Mexico at the moment. And FDA, well, that's another story. So what exactly is hyperthermia? Hyperthermia is the use of heat. And there are a number of ways of delivering heat. We're specifically speaking about heating tissue somewhere between 38.5 and 45 degrees Celsius. As Canadians, I'm going to be speaking in Celsius, so for my American colleagues, I apologize. Maybe Sarah can jump in with some quick Fahrenheits, but so we're looking at 38.5. That's the beginning of what we call the fever range, and that's relevant for whole body hyperthermia. This is where the whole body is heated. There are a number of ways in which this is accomplished. The one that we're familiar with is infrared heating of the body using external heat. There are hot baths. There are a number of ways of doing whole body hyperthermia. The infrared heating is the most commonly used worldwide. And most doctors who use whole body hyperthermia are using fever range whole body hyperthermia between 38.5 and 40.5 degrees Celsius. This takes about 4 to 6 hours. It requires a lot of screening for contraindications. The patient's very well monitored. Saline and dextrose are being put into the patient throughout the visit. They are being monitored head to toe. So that's the fever range. But when you're looking more at hyperthermia techniques where you are going for less of an immunologic, I won't say less of an immunologic intention, but the intention is also that of direct cytotoxicity or cancer killing. You're looking at the 42 degrees Celsius range and higher. This is known as the Arrhenius line. So if you just quickly look at this diagram, you can see radiative hyperthermia. That's where the hyperthermia is being radiated from a site into the body. Intraluminal, where it's put in through some lumen, and there's direct heating done with something like a catheter. Capacitive is the hyperthermia that we're going to be focusing on. This is the type of hyperthermia that we use in our clinic and across Canada. All the other NDs that are now using hyperthermia, the equipment is capacitive. That means there is a capacitor or a plate both above and below the patient where the target is, and radio frequency is being transmitted from one plate to the other millions of times per second in an alternating field, and that is what is heating the tissue. And as you can see in that diagram, capacitive hyperthermia allows for both superficial and deep heating. Just as a note for those geeks out there, radio frequency that we use is at 13.56 megahertz. And the device that we use also adds something called modulation. So it's also known as modulated electrohyperthermia. So if you're ever doing a Google search on capacitive hyperthermia, you can also look at the modulated electrohyperthermia citations. I think that's it for that. So some very basic fundamentals about hyperthermia and its use in oncology. So as I mentioned, there is a direct cytotoxic effect that occurs at about 42 to 42.5 degrees Celsius, or the Arrhenius line. And essentially that heat causes a number of molecular and cell membrane changes to the cancer cells. And I should mention there's a difference. Healthy cells have a higher thermotolerance than cancer cells do. So where cancer cells are being damaged at 42 to 42.5 degrees Celsius, typically healthy tissue is able to survive to temperatures of 55 degrees Celsius or higher. So that thermotolerance differential between healthy cells and cancer cells is something that we can take advantage of. So there is evidence that hyperthermia at that temperature range causes direct cytotoxicity. It's also well documented as a chemotherapy sensitizer. There are many reasons for this. I'll just briefly touch on a few. Where we apply heat, vasodilation occurs. That vasodilatory effect increases blood delivery and therefore drug delivery. As most of the listeners know, that tumors create blood vessels through angiogenesis, and those angiogenic blood vessels are not healthy like ours, and when they go to dilate, they leak. So this allows for better penetration of the target tissue with the chemotherapeutic agents that are circulating at the time that the hyperthermia is administered. There are a number of other reasons why, cell membrane permeability, etc. But very briefly, those are some reasons why we know chemotherapy is sensitized. Radiation sensitizers, there's good evidence that hyperthermia is one of the most effective radiation sensitizers, predominantly because of that vasodilatory effect and increased oxygenation of the target tissue. That leads to the next one. So we know that that hyperthermia does improve tumor oxygenation, and we assume that this also has some actually anti-angiogenic effects by reducing HIF1, hypoxia-inducible factor 1, which then reduces VEGF. And so, yeah, there's some additional benefits to tumor oxygenation in addition to being a radio and a chemosensitizer. Interestingly, hyperthermia has been shown to induce P53. So we know that one of the reasons why people can become resistant to certain treatments or their disease becomes resistant to most approaches is because of P53 being turned off, and then hyperthermia has been shown to re-induce that P53. And lastly, on this slide, there's good evidence that hyperthermia improves the delivery of liposomal drugs by improving cell membrane permeability. And there is quite a bit of research going on in marrying or combining the use of hyperthermia with liposomal drug delivery systems. We have seen in our clinical experience over the past 8 years patients who were previously not responding well to liposomal doxorubicin or Calyx, and when we added the hyperthermia to their treatment, we did notice that there was an improvement to local tumor control. So hyperthermia has been around for a while now, let's say a good 30 to 40 years of research on localized hyperthermia as we know it today. And there have been a number of positive randomized trials on the use of hyperthermia, most recently a large sarcoma trial. There is high level evidence that the addition of hyperthermia can improve local tumor control, as well as overall survival in a handful of solid tumor types. Most trials where hyperthermia is combined with radiotherapy or chemotherapy have demonstrated a significant improvement to the local tumor control as well as survival advantage. And then, as I said in the introduction, some of the more recent literature that we have interest in using capacitive hyperthermia, it will be reviewed later in this presentation by Dr. Souls. So for some additional information on mechanisms of action, the known immune effects, the heat shock protein thing, dendritic cell effects, the increase in innate and adaptive immune cells with hyperthermia, the topic of thermotolerance, too much of a good thing can be too much, some of the various heat shock proteins, some of them being, we think, good, and some of them possibly not being so good, and creating thermotolerance. And then the more detailed mechanisms of action for chemo and radiosensitization, there is the previous ONC-AMP lectures are available to all ONC-AMP members, and please feel free to look at any of that information. And if you still have questions burning you, please don't hesitate to reach out to myself or Dr. Souls. So just as a brief introduction to how this all came to be, Sarah actually put this whole talk together, so she gets all the credit. And I sent Sarah a number of pictures of various trips I had taken to European countries, particularly Germany, but a bunch. And of course, we can't just sit here looking at all these wonderful photographs, although it would be nice for me, because they're all good memories. She's chosen a couple of pictures here to for me to talk about. On the left, Clinic St. George. The doctor, the oncologist that runs Clinic St. George is a guy named Dr. Frederick Dowes, and he's larger than life. He's a very open teacher. He's one of the people that was intimately involved in the development of capacitive hyperthermia devices as we know them today. He's been using hyperthermia for 3 decades, and he's been one of my great mentors over the years. And I've had the good pleasure of visiting him at Clinic St. George several times, which is in a beautiful little town called Bad Aibling in the south of Germany in Bavaria. So you fly into Munich and go there. It's a beautiful, beautiful place. To the right, that's Dr. Stefan Hiller, and he's an oncologist at Felder Clinic, which is a beautiful, incredibly impressive hospital. What's it called again, Sarah? What's that? Started in Germany. A lot of MDs or these sorts of doctors. Anthroposophical hospital. So this is an anthroposophical hospital, and Dr. Hiller is very impressive. He's also somebody that has been combining hyperthermia, both regional and whole body, with his chemotherapy or targeted agents or even immunotherapy. He's been using mistletoe for many years as an anthroposophic physician. And for anybody that is attending the IMM conference, a little plug for the IMM conference in Germany this September. One of the things that you can do is go for a tour of Felder Clinic, and Dr. Hiller is the person that would show you around, presumably. He has been in the past, and if you ever have an opportunity to visit that place, it's well worth seeing. Their birthing center is just incredible, all live, I believe it was something like 98% natural births. But yeah, very impressive hospital. So it was, repeated visits back and forth to Germany and Switzerland and Austria and Holland and some of these places where they use hyperthermia a lot more than we do here in North America, dating back to 2001. And really my interest grew greatly in 2004 when I attended Medicine Week for the first time. And I was introduced to multiple hyperthermia devices and doctors that were using it, and that really spurred on my interest. And then it was repeating those sorts of visits and many years of planning and Health Canada approvals and all of that that has brought hyperthermia to the country. And I mentioned one of the disclosures was that I have interests in this company called Tenevita. After the many years of determining which hyperthermia devices, how, etc., going through 2.5 to 3 years of process to get the device approved in Canada first with a special access license, which allows you to bring in one device, and then ultimately to what's called a Class 3 medical device license, which allows the importation and sale of the device, which was a big job, and we're very happy that it was successful. We were well positioned to help other doctors bring these devices into their clinics, and I'm open about that disclosure, and I'm actually quite proud of what we've been able to accomplish in a relatively short period of time in bringing a new modality into our profession. I think that's good for that slide. So we first introduced the local regional device in our clinic 2010. It was the summer of 2010. It was challenging to get to that point, and we were very happy to get started. We had a number of patients waiting for the treatment by the time that we had gotten to that point. And then we added a second device in 2011. So we currently operate 2 capacitive local regional hyperthermia devices. Dr. Eric Marsden from Ontario was the next to introduce hyperthermia into a naturopathic clinic, and he did so in 2013. And I was very happy that the first person that was bringing it in was Dr. Marsden. I have a great deal of respect for him. He's a clinically astute guy, and is very detail oriented and had all the right ingredients to be a successful naturopathic oncology professional using hyperthermia, and he has been doing very well with that service. The next year, in 2014, we had both Dr. Sharon Gurm here in the Lower Mainland in Port Moody, and Dr. Matt Pyatt in Calgary, Alberta. So now we're now in 2014 in British Columbia, Ontario, and Alberta. So Dr. Gurm and Dr. Pyatt both introduced hyperthermia, the capacitive local regional Oncotherm hyperthermia device to their practices in 2014. And every time I have the opportunity to meet with them and speak with them, things are going well for both of them as well. And I hear through patients and common people that we have the opportunity of working with, referrals, etc., that they're doing great work. In 2015, we had our second clinic in Ontario with Dr. Michael Reed, and our second clinic in Alberta, now in Edmonton, with Dr. AJ Deneau. They have also been doing very well with hyperthermia. We've been, you know, as a community of hyperthermia users, we have a little chat group, and Mark and I have organized for us to get together a couple of times, and so there's some good cross collaboration, and we're able to post questions for one another, and so that's been very nice. And so Dr. Reed and Dr. Deneau in Edmonton, and in the Tri-City area for Dr. Reed. And then most recently, Dr. Sean Caesar in Winnipeg, Manitoba, and our third clinic in Ontario, Dr. Michael Pertula. And just so you know, Dr. Michael Pertula and Dr. AJ Deneau, the reason why there's no pictures of their clinics is not because we didn't want them to have some pictures. They just didn't have the opportunity to share any with us for the talk, which is why they're not shown. But we wish all of the doctors now using hyperthermia in their clinics the best of success. And we hope, as we have, they notice that the addition of this treatment has improved the outcomes of their patients and their expectations for their patients. So Corey, I just saw that message right now, and I didn't realize that at all. So I'm happy I wasn't doing funny things. Yeah, it's fine, whatever. I'm almost done now. So I just found out that I was on the webcam the whole time, and I didn't realize that that was going to happen. So if you guys have all been watching my funny little things, I don't know what I was doing. Hello. Okay, so we end my piece of this talk, this webinar, with this wonderful slide. Again, Dr. Souls gets all the credit. I wouldn't have known how to put those red bubbles with the numbers, and the numbers correspond to when, you know, west to east. It's so nice. That is our current map of hyperthermia in Canada. Pretty exciting. You know, there's a little bit of a gap there in Saskatchewan, a bit of a gap in Quebec and the Maritime provinces. Subsequently, all of these doctors that are offering capacitive hyperthermia are seeing patients from all over the place, including the US, and we do our very best to provide the patients that come with the best care that we can, and then we send them back to their attendings wherever it is they live, complete with consultation letters to say thank you very much, and this is what we did, and now they're yours. And so with no further ado, I'd like to turn the floor and camera over to Dr. Sarah Souls, or unless of course she doesn't want that, I don't know. You guys are in great hands, and I look forward to hearing this.
Thanks, Dr. Parmar. I think I'll leave my camera off. But the purpose of this section of the webinar is to bring you all up to speed on the most recent literature in the realm of hyperthermia. And I'm going to use this paper as a launching point for the newer studies that I'll be discussing shortly. So just a note for everyone, the hyperthermia that I'm referring to in all of these studies is the local regional hyperthermia, not whole body hyperthermia like Dr. Parmar referred to before. So this 2015 review is my go-to reference to summarize the utility of hyperthermia at enhancing the effects of radiotherapy and chemotherapy. The authors present this beautiful summary table of studies that compare the response rates of treating with radiation and or chemotherapy alone versus radiation and or chemotherapy plus hyperthermia. It includes cancers of the breast, the cervix, head and neck, rectum, urinary bladder, esophagus, lung, and a few other odd cancers, including melanoma. It provides the odds ratios, which show that for most of these cancers, a complete local response is significantly more likely when chemotherapy or radiation is combined with hyperthermia. So if you're looking for a relatively recent review on the subject, I'd strongly recommend checking this one out. Okay, so now getting into some of the more recent studies. This one was published in February of 2016, and the trial was originally designed to investigate the effectiveness of radiation plus hyperthermia compared to radiation plus chemotherapy in locally advanced cervical cancer. Unfortunately, due to poor recruitment, the trial was closed early, and the population ended up being more weighted towards earlier stage cervical cancer patients, but the results that they found were still interesting, so I wanted to include in this presentation. For those of you who aren't familiar with this PICO format of answering clinical questions, the acronym stands for, the P stands for population, the I for intervention, the C for control or comparison, and the O for outcome. So this paper was looking at a population of 84 women with stage 1B to 4A cervical cancer who were undergoing external beam radiation with brachytherapy. The intervention was radiation plus weekly hyperthermia treatments for a total of 5 hyperthermia treatments. The control was a group of women who received radiation plus weekly infusions of cisplatin. The primary outcome that was assessed here was event-free survival, and this was defined as the time from randomization to the time of the first event, which could be an incomplete response, a relapse, or a cancer-related death. In my opinion, this isn't exactly the most useful outcome to assess, but thankfully the authors also looked at overall survival in addition to pelvic recurrence-free survival and late radiation toxicities. This graph on the right is a representation of event-free survival, with the hyperthermia and radiation group being the points in white, and the radiation plus chemotherapy group being the points in black. The authors found that there was no significant difference between either of these two groups for event-free survival. This was also the case for pelvic recurrence-free survival, for grade 3 or greater late radiation toxicities, and for 5-year overall survival. So what does this actually mean? Essentially, combining radiation with hyperthermia may be just as beneficial as combining radiation with cisplatin in cervical cancer. I do, however, need to point out that due to the low recruitment numbers, the study was underpowered. So it is possible that there just weren't enough patients to tease apart any difference between these two groups. So for this reason, the authors suggested that adding hyperthermia to radiation can be a good option if chemotherapy is not possible for whatever reason. In our practices as NDs, where some of our patients are adamantly against chemotherapy, if we can at least convince them to add hyperthermia to radiation, at least we know that this is still a good option that may provide equivalent outcomes to radiation plus cisplatin. Next up is this 2017 phase 3 study that looked at using hyperthermia adjunctively with radiation for painful bony metastases. The population was 57 patients with painful bony metastases and a brief pain inventory score of 4 or greater. The intervention was hyperthermia 2 times per week for 2 weeks, in combination with 10 fractions of radiation. And this patient population was compared to another group of patients who received the 10 fractions of radiation alone. The outcomes that were assessed were pain scores within 3 months after treatment. So I'll start the results by saying that this trial was initially designed to recruit 150 patients, but after the interim analysis, the authors decided to terminate the study early because they deemed it was unethical to treat with the radiation-only arm, which is pretty amazing. This is because the complete response rate at 3 months was 37.9% in the hyperthermia plus radiation group, and only 7.1% in the radiation alone group. In addition to this, the pain relief lasted longer when using hyperthermia. The median time to pain progression was 55 days in the radiation alone group, and this time to progression was not reached after the 24-week study period in the hyperthermia plus radiation group. The authors also performed some radiological assessment after 3 months, and this was done in a smaller subset of the patients, and they found that 5 out of the 12 patients in the radiation alone group showed some evidence of radiological progression, whereas no patients in the hyperthermia plus radiation group showed progression. So I think the conclusions for this trial are pretty straightforward. The addition of hyperthermia to radiation for localized painful bony metastases can significantly improve pain control, and it can prolong the effects of the radiation treatment. This phase 1 study, published in November of 2017, was designed to assess the safety and pharmacokinetics of high-dose intravenous ascorbic acid, which I'll refer to as IVAA here. And this was done alongside local hyperthermia in patients with advanced lung cancer. The population here was small. It was only 15 patients with stage 3 or 4 non-small cell lung cancer who had progressed on conventional therapies, and this included radiation and or chemotherapy, as well as targeted agents. I will also note that none of the patients here were allowed to have any additional conventional treatments throughout this 4-week study. So the intervention was intravenous ascorbic acid given 3 times a week for 4 weeks in conjunction with hyperthermia. The dose of the IVAA varied. It started at 1 gram per kilogram for 4 treatments, then was increased to 1.2 grams per kilograms for 4 treatments, and finally 1.5 grams per kilograms for the last 4 treatments. The comparison here had to do with the timing of the hyperthermia administration. So everyone received the IVAA, and it was either given prior to hyperthermia, given during hyperthermia, or given following hyperthermia. They were assessing the safety, tolerability, and pharmacokinetics of the IVAA given alongside hyperthermia. So I'll bring your attention to this graph here on the bottom, which shows the plasma concentrations of ascorbic acid over time for the various IVAA doses. So your 1 gram, 1.2, and 1.5 grams per kilogram. Now you can see what really stands out here is this purple line, which has a significantly higher peak in the plasma concentration of ascorbic acid. And this line represents the group that received their IVAA during hyperthermia treatment. The authors also looked at toxicities during these 2 treatments and found that they were minimal. So thirst was the greatest complaint in all groups, which isn't surprising considering the high osmolarity of the vitamin C can cause some dehydration. Fatigue, nausea, vomiting, facial flushing, diarrhea, and headache were also reported. There were also no hematological or serum creatinine abnormalities. And finally, quality of life improved. So they noted some significant improvements in fatigue, dyspnea, insomnia, appetite, and diarrhea. So from these results, what we can take away is that combining IVAA with hyperthermia is safe, it's well tolerated, and it may improve the quality of life in patients with advanced non-small cell lung cancer. In addition, administering IVAA and hyperthermia at the same time may increase the max serum concentration of ascorbic acid. Although we don't really know the mechanism of why this happens, assuming that we want to achieve the highest possible serum ascorbic acid concentrations, this study suggests that the best way to do this is by administering IVAA at the same time as hyperthermia. Of course, whether this can result in any greater clinical outcomes is still to be determined, but may be an interesting avenue for future research. Our next study was published in December of 2012, and it retrospectively looked at the efficacy and cost effectiveness of hyperthermia in conjunction with dose-dense temozolomide for patients with recurrent glioblastoma. Here are 54 patients with recurrent glioblastoma were given dose-dense temozolomide plus hyperthermia every 3 days. And this group was compared to 114 patients with glioblastoma from previously published cohort studies who received temozolomide alone. The efficacy of the treatment was assessed by median survival time, and the authors also discussed the overall cost of the treatments. What the authors found was that mean survival time was not significantly different between the 2 groups. However, the hyperthermia group received far fewer cycles of temozolomide compared to the cohorts of patients who received the temozolomide alone. This suggests that the hyperthermia enhanced the effects of the temozolomide to produce a similar survival response with giving fewer cycles of the drug. Likely as a result of the decreased number of temozolomide cycles, No high-grade toxicities were seen in the hyperthermia group, whereas these grade 3-4 toxicities were found much more often in the cohorts where temozolomide was given alone. So anywhere from 45 to 92% of the time, depending on the study. The authors also estimated the cost of treatment per person. So using a US model, they calculated that the average cost of treatment for an individual in the hyperthermia group was just over $15,000, whereas the average cost of someone in the temozolomide alone group was over $26,000. Using these values, the authors estimated that to treat 1,000 patients for 1 year using a combination of hyperthermia and temozolomide, this would result in savings of roughly $11.5 million per year. Of course, that estimate is based on the data that I just discussed, that suggests that hyperthermia makes temozolomide more effective, and therefore fewer cycles of the drug are necessary for equivalent survival time. I do need to point out the unfortunate limitation of the study, which is that we cannot accurately assess the full impact that hyperthermia can have on overall survival. And I say this because the median number of cycles of hyperthermia and temozolomide that were given was only 1. In 85% of the cases, hyperthermia was not discontinued because of disease progression, but rather because of patient or physician preference or for financial reasons. Many clinics, including the Integrated Health Clinic, will use hyperthermia over several temozolomide cycles, and clinically I can say that we've seen some really impressive responses in our glioblastoma patients. Okay, so there was a lot to take in with the study, but what I want you to take away from it is that hyperthermia may enhance temozolomide efficacy, and because of this, it can be a cost-effective option. However, we still need a good quality prospective study to really see if adding hyperthermia to temozolomide for multiple cycles can improve overall survival. This last study was just published this year, and it was also just mentioned in the latest OnCAMP newsletter, so some of you might already be familiar with it. The report was of 2 cases of women with metastatic pancreatic adenocarcinoma. The intervention was adding local hyperthermia in conjunction with FOLFIRINOX chemotherapy. I'll note that both patients did also receive additional supplementation, which included curcumin, polydadin, lactoferrin, AHCC, melatonin, and mistletoe. The authors then compared the disease burden and the overall survival in these 2 cases with what is expected for similar cases without additional integrative care. What they ended up observing was that the tumor markers and the liver enzymes in these 2 women decreased throughout the treatment. And then in both cases, the CT scan after 6 cycles of treatment showed that there was a complete disappearance of the primary and metastatic disease. Both patients remained in a state of no evidence of disease at the time that the authors wrote the paper, which was 30 and 36 months after the date of diagnosis. So the authors compared this to the typical course of disease in patients with metastatic pancreatic cancer, and they pointed out that treatment with FOLFIRINOX will often result in a reduction in the tumor size, but rarely does it result in a complete response. In addition, the prognosis of similar patients typically ranges from 2.5 to 12.8 months, depending on the study. So these patients continued living well beyond average. The conclusions here were that an integrated approach to pancreatic cancer that includes hyperthermia certainly has the potential to result in a complete response and a prolonged disease-free state. I wanted to end this presentation by briefly mentioning the impact on survival that Dr. Parmar and other doctors at the Integrated Health Clinic have documented by including hyperthermia in their naturopathic treatment approach to cancer. Some of you may already be familiar with these graphs because Dr. Parmar has presented them at previous conferences, but they represent data collected from advanced cancer patients at the Integrated Health Clinic who were treated with hyperthermia between 2010 and 2015. You can see that for stage 4 breast and ovarian cancers, these patients had 5-year overall survival rates of greater than 50%. Compared to the SEER Cancer Statistics Review, where 5-year survival was 27% in metastatic breast cancer and 29.2% in distant ovarian cancer, the survival rates at the Integrated Health Clinic were much higher. This was also the case for stage 4 colorectal cancer, where our patients had a 38.8% 5-year overall survival compared to SEER's 13.8%. Glioblastoma is another cancer where we've seen some great success. One recent study estimated a 10.3 2-year survival in this population, whereas patients at the Integrated Health Clinic had a 2-year survival rate of 47% and a 5-year survival rate of 27%. Of course, some of the improvements in survival are likely because of other treatment recommendations that were made. But based on the abundance of data supporting the efficacy of hyperthermia, we strongly believe that some of the survival improvements are related to the hyperthermia treatments. So just to summarize with a few take-home messages, hyperthermia can act as a potent radiotherapy and chemotherapy sensitizer. This was illustrated in the cervical cancer, recurrent glioblastoma, and the painful bony metastases studies that I discussed. And then because of its ability to enhance the efficacy of these treatments, hyperthermia can also be cost-effective. Finally, as Dr. Parmar went over, hyperthermia is available across Canada through several experienced NPs. So if you're wondering if hyperthermia is indicated for any of your patients, please don't hesitate to contact myself, Dr. Parmar, or any of the NDs that were listed earlier who offer this treatment. So I just wanted to thank you guys so much for listening, and I hope myself or Dr. Parmar can answer any questions that you guys might have.
Great. Thank you guys for such a wonderful presentation. So audience, if you have any questions, feel free to, again, as I said in the beginning, you can type them in the GoToWebinar question box, or if you have a question that's a little bit more involved or that would be easier to say verbally, you can just press the kind of raise your hand, little hand icon there, and I can unmute your line and you can ask that question out loud. So I will give people a second. Let's see, it looks like we have a question from Daniel. Daniel, I'm going to unmute your line. Okay, you should be able to unmute yourself, Daniel, if you press the little audio kind of little microphone option. Oh. Let's see here. I'm not sure if that's coming through right now. In the meantime, while he's hopefully maybe figuring out how to unmute his line there, it looks like we've got a question coming in. Question from the audience. Have you seen success with hyperthermia used without chemo or radiation in those patients that refuse?
Shall I take that, Sarah?
Sure, you have the most experience here.
And yeah, and you know, if you can think of any examples over the past little while, please feel free to jump in. So yeah, we have used hyperthermia in both those people that have refused standard of care at some time of their treatment, or for those patients who have exhausted all of their treatment options conventionally, and we're now using hyperthermia on a salvage basis. We've seen hyperthermia, and I'll define what work means. We've seen hyperthermia create shrinkage. We've seen areas of disease where there's no evidence of disease after treatment. And so, yeah, I can think of most recently a patient who had renal cell carcinoma, a tumor in the left kidney that was basically cut in half by 12 treatments of local regional hyperthermia. We've had patients with recurrent disease in an area where they had previously had, let's say, mastectomy, and then followed it up with adjuvant radiotherapy and chemotherapy and hormone blockade, and now they have a recurrence in that chest wall, and they cannot do further radiation in that area. In some cases, radiation oncologists might give some more, but in many cases they won't. Just the risk is too high. And we've seen responses in very tough situations like that. We've had patients with metastatic colorectal cancer with liver metastases and lung metastases, where after a 6-week treatment protocol of local regional hyperthermia and fever range whole body hyperthermia, we've seen complete responses. This past OnC-AMP conference, I presented a case of mine with malignant melanoma. This patient had melanoma in the neck, in the right side, in the right neck, in the right side of her brain, palpable lesions on the scalp itself, as well as in the right side of her brain, in the right neck, in her liver, and without the use of any conventional therapy after a cycle of hyperthermia. And of course, everything else that we do as NDs, that patient had a complete response, no evidence of disease, and she is, I believe, close to 5 years from that time. So yes, we have.
Fantastic. All right. Next question from the audience. When is full body hyperthermia indicated in comparison to local regional?
So whole body hyperthermia is typically indicated when a person is looking for an immunologic benefit. So the addition of fever range whole body hyperthermia to whatever treatment they're doing, whether it be immunotherapy or they have widely metastatic disease, and you can't just pick one area or spot to treat local regionally. They have widely disseminated disease. That's an indication for whole body. And I'd also say that whole body is indicated in the secondary prevention setting, where a person's now completed all treatment. They're now no evidence of disease. They're now looking for something to help keep them in remission. This is another indication for whole body hyperthermia. And local regional hyperthermia, we typically use it where there's a tumor, where there's an area of disease burden, pre and post surgically, if there's going to be a surgical resection taken. Sarah, what am I missing?
In cases where somebody has chronically low white blood cells or red blood cells, it can also be useful.
Great. All right. Daniel, I'm having a hard time unmuting your line, so I don't know if you still have a question, but if you do, you could go ahead and type it. Any others out there that have any questions? As both Dr. Souls and Dr. Parmar said, and as you can see from their screen there's their contact information. So you can obviously feel free to contact them directly. Or you can always pass something through the ONC A&P and we can deliver it for you and get those answers for you. But without seeing any additional questions right now, I think we can just give another thank you so much to both of our presenters tonight. Thank you all for attending. Oh, wait, another one popped up. Got in there really quick. Would whole body hyperthermia increase chemotoxicity if used in conjunction with it?
That's a very good question. Whoever asked that question. Sarah, do you want to take it or shall I?
I'll let you cover it.
So I would say that a researcher named Joan Bull, Bull, at MD Anderson has probably done the best work on what's called thermochemotherapy. So the combination of chemotherapy with whole body fever range, whole body hyperthermia. And yes, it's a good question. For platinum drugs, for example, the whole body hyperthermia is not given concurrently because there can be increased nephrotoxicity and neurotoxicity. So for platinum-based chemotherapeutic agents, usually the whole body is administered about 72 hours after. So that's one example. And I would say that for, fluorouracil, 5-FU, for capecitabine, gemcitabine, for any drugs that have a very short half-life, and for which there's already evidence of a safe combination. There are not too many drugs that we know of where there is an increased toxicity by adding whole body, but I would certainly say that for the platinum drugs that is the case, and also for the taxanes there's a delay, 24 to 48 hour delay that's recommended for the same reasons, neurotoxicity and nephrotoxicity.
All right. Way to get that question under the wire right before I was about to sign off. Fantastic. Well, thank you guys all again so much for being on, for presenting. For those of you who are listening to this on the ONC A&P member site, the recording, same thing. Feel free to contact the ONC A&P or the presenters if you have any follow-up questions. And everybody have a wonderful rest of your evening.
Thanks, Corey. Thanks, Sarah. Thanks, everybody.
Thanks, everyone.
Good night, everybody.